I'll share my screen here to bring up the presentation. So some of you may be familiar with motivational interviewing, and this is the type of course that we tend to run as a workshop situation, so we can actually practice some of the skills. So hopefully perhaps we'll be able to do something similar next year when we're face to face. But so this is a very cut down version of what we might talk about to introduce motivational interviewing as a technique, as a communication entity. And hopefully it'll just spark some interest that might give you a platform to go off and explore a little bit more. So this is what we've kind of alluded to, what Subhadra was alluding to in the introduction, is the idea that sometimes information is just not enough to change our behaviour. And so I want to introduce Frank to you, and we're going to talk about how at the most extreme scenario, where it's life and death, that information that has a threat value about life and death is still usually not enough to change people's behaviour. So this is Frank. Frank had a heart attack, and he's been told that he needs to exercise by his healthcare professionals. This is the information that they give Frank. So they say to Frank, it's really important that you exercise. You must do this because rehab after a cardiac event can reduce the chance of you dying in the following year by 25%. That's a big whack when we're talking about life and death. So you should heed this advice, Frank, and get on with it. And even if it saves your life, it also makes your quality of life a lot better. So you know, things should go better for you. So Frank thinks about this, and he thinks, I don't want to die. I've still got a lot to live for. I want to do some travel. I want to meet people. I want to play golf. I want to do all these fun things. And so what does Frank do with this quite scary, threatening information and education that he's been given? When we look at the studies and we look at how many Franks who've had a heart attack actually go on and do rehab, what we find with this type of information is that only about 30% of Franks will actually go and do the cardiac rehab. Now, down the track then, after 6 months, we find that of the 30% that actually engaged in the rehab, only 30% of those will be continuing to exercise. So 30% of 30% down the track. So really what this sort of shows is that information and threat and education is not enough to change people's behaviour. And we know that because we often know what needs to be done for us or what's the right thing to be done, but it's not often enough to change our behaviour. So looking at using motivational interviewing, MI, as a entity to help people change their behaviour, most of the times for us as healthcare professionals, manual therapists, we're using it to get them to do things like exercise. So when we use MI compared to other or standard normal techniques, and we look at the systematic review and we look at the lectures, what we see is that there is moderate level evidence to show that it has a small effect in increasing physical activity in people with chronic health conditions compared to comparison groups. So the comparison group would be education alone. And that's a small effect size. It's not going to change things very drastically, but it is showing that there is some evidence of efficacy for choosing this type of approach. Again, looking at another systematic review, so small to moderate overall effect of MI on increasing adherence to treatment from baseline to intervention, but not following that. So sort of saying that as provided there is checking in and ongoing, I guess, coaching in this scenario, that it is, again, small effect size for efficacy. Now, the text that I tend to use when I'm teaching this is this one on the right-hand side, the Miller and Rolnick. It is the gold standard to come back to, learning about motivational interviewing. And often when we're working on the skills in the workshops, we use that book on the left as a bit of a guide. It would definitely be if you want to delve into this a bit more, the book on the right there would be the best place to start. And I will pass on these notes to the committee afterwards so that you can have access to these. So a lot of what we do is about communicating to our clients and often about motivating to change behaviour. And so what MI does is it involves paying attention to people's natural language about change. And then using these natural or innate motivations to help in a coaching setting to create some structure for that person to focus in on their own desire to change behaviour. And the opposite scenario is probably the one that is a bit more reflective of the traditional healthcare settings. So the one where people are told what they should do. And we're using educational, sometimes we're using shame, sometimes we're using threat to get people to do something. And I'm just going to talk a little bit about some theories around why that doesn't always work. So when we look at communication styles, we look at this sort of spectrum, this idea that on one hand, we've got that directing style. So we've got, we're telling people what they should do, we're sort of ordering them. On the right-hand side of that, we're following them. So we're kind of allowing the client to, I guess, guide us, to be the boss. And then somewhere in the middle is kind of what we're aiming for with motivational interviewing. It's really supposed to be about collaboration. So in that director role, we're sort of putting ourselves out as the expert. We're telling people, some of the words that it invokes: managing, prescribing, telling, order, leading. In the following, at the other end of that spectrum, what we're kind of thinking is we're showing interest, we're understanding, we're exploring together. So other prompting words: allowing, listening, going along with, observing, permitting, and valuing. And that's certainly great, but we need to do that. That's a really important part of building rapport, and for the client to feel that they're heard and that they're part of the decision-making process. It's harder to get things done when we're only focusing in that space. So that middle space that we're looking for is sort of guiding. So we're listening, skillful guidance, accompanying, collaborating, encouraging, motivating, showing, and offering. The writing reflex is a concept that's quite central to understanding MI a little bit, and it's the idea that we as practitioners, we often know the answers. So the client comes in and they tell us something and we might think it's wrong, or we might think we know what is right for them. So perhaps we think we want them to start exercising, or perhaps we think we want them to spend less time sitting at the desk or something like that, whatever it is that we think we know is right for them. And it's a bit of a natural human thing to then jump up and want to tell people what they need to do. And so that can become a bit of a problem. We'll talk about why that can be a bit of an issue. So we can sometimes end up in this space where we're dragging things along a little bit. So some of the concepts about this, so readiness to change, or being in an ambivalent space, is often what we're hearing when people are thinking about making a change in their behaviour. So ambivalence is quite normal. It's often the idea where people recognise that change is hard. They've got mixed thoughts or feelings about it. And sometimes those thoughts and feelings are just jumbled up in their mind. They don't necessarily have a coherent flow about those different ideas. And so recognising and listening for ambivalence is kind of what we're doing for in the behaviour change game. So it's when a person can see reasons to change, but also see reasons not to change. And it's that first step, because at least they're in a space of consideration. So in a spot before that, they're probably pre-contemplative, and that's a space where other people might think that you need to change, but you don't. So being in that ambivalent space is when you're starting to consider making a change. But it's also the most common place for people to get stuck. So that's where we as kind of, I guess, in a coaching space can be really helpful to help people make that next step. So most people know what the right thing to do is. And so we come back to Frank. Frank knows that he probably needs to do exercise. That's not, it's a bit of a no-brainer. Society knows that, his family will be telling that, his doctors are telling him that, and yet it's often not enough to change behaviour. So most people know what the right thing is to do, and if the knowledge was enough, then we wouldn't need to be talking about it too much more. So if just knowing was enough to make us change our behaviour, that would be end of it. But we know that that's not the case. So the ambivalence, we're listening for change talk versus sustained talk. So change talk is the idea that we're listening for self-statements that favour change, and sustained talk is the self-statements that are expressed about the reasons not for change or not changing. So this kind of listening for this kind of internal tug of war that people will present with. And the other thing that we'll often see is this yes but kind of cadence. So people often might have the pros and cons in their head. And so what tends to happen when someone is vaguely thinking about making a change, they've got the reasons to change, the reasons not to change in their head, but they haven't really put it into much of a coherent flow. They haven't focused in on it enough. What we tend to find is that when someone who is in that space where they're kind of holding these two thoughts very loosely in their head, when they might meet a practitioner who has a very pro-change approach, who's thinking, let me tell you what's good for you about this, this is what can tend to happen. So when we get someone who is in this ambivalent space and we make them argue the pro-change side, what it will often do, if we argue the pro-change side, what it will often do is make the other person verbalise the sustained talk a bit more. And what we find is as soon as someone puts that coherent thought and says it out loud, the biases with that say they then tend to believe it. So if we push them to verbalise one side of an issue, it tends to move the balance of that person's opinion in that direction. And so what we can end up with, if we are sort of pro-change and we make them verbalise the reasons not to change, we end up in this oppositional conversation style, and it can become quite clunky and quite unproductive. So again, if we've got someone who's got these two thoughts in their head, what motivational interviewing is looking for is we want them to verbalise the pro-change, not the sustain side. So it's a series of communication techniques that help to foster that idea. So people are more likely to be persuaded by what they hear themselves say. Let's see, that's the kind of idea. When we start breaking down and looking at the skills for motivational interviewing, the main ones that we tend to hone in on are these four. So open-ended questions or Socratic questioning, affirming, so making statements that help the patient to feel acknowledged and that we're seeing that they're doing a good job. Reflecting, so we're demonstrating that we're listening to what they have said and that we're present in the conversation, and we're trying to be, I guess, curious as to what they're saying. And then summarising as a skill to sort of, I guess, bring the control of the conversation back and maybe give it a bit of direction. So open questioning is, open questions are those that have more than one word answer. We're really sort of asking very broad questions and allowing the person to go down and really think about what is in their mind. So, and really, if we let curiosity drive that process, it's as simple as that. So we don't have an answer in mind, the same like we do with a closed question where we're thinking we almost already know what the answer is going to be. With an open question, what we're hoping is with that curiosity, we don't know what the answer is. We really just want to let the person come up with the answers themselves and dig in a little bit. So we're showing a genuine interest. We're not interrupting. We're kind of opening a door for them. So some interesting questions, open questions that I might use. How does pain interfere with your life? What made you you come to see me now? And that question, what that's looking for is why now? Why not a little bit before? Why? It's drawing on their motivation. What made you? What did you want to change? Or what prompted you to come in? What do you hope to get out of treatment? Tell me your story is my favourite one for asking people, particularly about their chronic pain stories. And what made you think of that? Affirming, so coming back to the OARS acronym that we were using about the skills for motivational interviewing, the A is for affirming, so accentuating the positive, supporting and encouraging, helping to build rapport, and demonstrating that you've listened and understood. So really just statements that suggest that you care, basically, and often it can be a great skill to reduce defensiveness as well. So things like, you did a great job getting that much done. I can see you might be a bit disappointed, but I think you should be really proud of yourself. You've done a great job there. Your intention was good, even though it didn't go as well as you would have liked. Well done for getting over that flare-up. You did a much better job than the last time it happened. And you did your exercises 5 days out of 7. Good for you. So just some simple statements. Often when people are learning this, and you present this as a concept, this sounds like it can be a little bit patronising. But interesting, when we go and do this then as a technique and you throw them in, and even if it's an exercise, even if you know you're working in pairs and it's a little bit artificial, what you find when you're in that experience and you're on the receiving end of that is it doesn't feel patronising, it doesn't feel clunky, it actually just makes you feel quite warm and fuzzy, even in that sort of artificial environment. Reflecting is probably one of the most important skills, and one of the ones that we can, it really is the quickest way to start building rapport with patients. So demonstrating that you're listening and understanding, encouraging a patient to continue or expand, and it can also allow for clarification. And when we're teaching MI, what we split that up into is simple reflections and complex reflections. So simple reflections are fairly close to what's been said. They're kind of showing interest, and they're encouraging a flow of dialogue. So they can even be what has been said. So you can even reflect back exactly what's been said, but otherwise staying fairly close to what's been said. Some examples. I had a good week with my exercises, but I'm still getting a lot of pain. So you're happy with the exercises, but the pain's still upsetting you. You can kind of see it's a bit like the thesaurus approach. You're jumbling the words up to show that you have heard it, you've synthesized it, you care enough to kind of reinterpret it, and you're feeding it back to them. I'm feeling depressed today. You might say you're feeling a bit flat today, or you're feeling kind of down. They're fairly simple reflections, fairly close to what the person has said. Complex reflections are reading a little bit more into a person's words. So you're taking a leap from what they've said, maybe taking a guess. You might reframe it a little bit, and they can generally move the conversation forward or add a chance for clarification. I'm feeling pretty depressed today, so you might say something's happened since we last met, or your mood's been up and down the past few weeks, or something like you don't look like you have much energy. And really what you're doing is you're taking a little leap from what they've said. And the beautiful thing about this is you can't get it wrong. And even if you do get it wrong, what you're doing then is you're allowing the person to stop and think. So if you said, say for example, the first one they said, I'm feeling pretty depressed today, and you said something's happened since we last met, they might say, no, actually nothing's happened. I don't even know why I'm feeling really flat today. Just doing that allows people to sit and pause and be with their thoughts a little bit, and that in itself can help them clarify what's going on. So that's a really thinned down and short introduction to some of the motivational interviewing techniques. And when we run it as a workshop, which I hope we do get the chance to do perhaps next year, what we do is we break down a lot of these skills and run them in a workshop setting. So we actually do work in pairs and practice some of these skills, and you find that you can take them away and use them straight away. They're really, really helpful for helping people to change their behaviour. They're obviously the foundational bits, and we get into the nitty-gritty about how to enhance the change talk and reduce the sustained talk, so that people are essentially talking themselves into change. Where to from here? So if this has sparked your interest, and I'd be delighted if it has a little bit. What I would suggest is that the first thing you do is you start practicing a bit of the reflective listening skills with family and friends, but as well then introducing it with clients. So start listening a little bit more and really being present when you're listening. So what's good about reflective listening, or what's good about practicing these things, is we often realise how hard it is to sit still and or to sit on our hands and not jump in and speak. Yeah, what people often find is that when we practice these, it's often quite hard. The other thing is, when we're often having a conversation, rather than being present, we're often thinking about what we're going to contribute to that conversation next. So we're not very present in the moment. We're not really listening to what the person's saying. In our mind, we're preparing what we're going to say next. When we bring that curiosity to a discussion and we're really genuinely listening, we are very present in the moment. We're really trying to hear what's being said. So that's a great place to start. The books that I suggested as well, Miller and Rolnick's the best place to go. And the way I'd suggest that you read that is to digest it really slowly. So it's not the kind of thing that, like a lot of communication techniques, it's not the kind of thing that you can just read and then suddenly you have that information and it's good to go. It's the kind of thing you pop it on your bedside, read a little bit, read 10 pages every night, take a skill from it and think, okay, I'm going to practice that tomorrow. I like to think about it like you're marinating in the concepts, that you're soaking them in and taking them on slowly. There's lots of YouTube videos out there about motivational interviewing as a skill, and there's also lots of online courses that are being set up, and particularly for manual and exercise therapists. There's lots of them going out there. I'm not going to advertise any particular ones, but yeah, I think it'd be interesting. If it sparks your interest, I think it's well within your scope to be learning this as a communication technique. So I'm going to stop sharing my screen and have a look and see if we've got any questions. So the best place is probably for me to come back. Are you back? Okay, great.
We're having, well, I've got one question that's just come through, and I'm just pulling it up so that I can ask it. My phone will do what I want it to do.
There's Leah. Hi, Leah.
The question, Alison, is how do you manage patients who are more in the eminence mould of healthcare, who want to cast you in the expert role?
Can you ask the question again? Sorry.
How do you manage patients? How do you manage patients who are more in the eminence mould of healthcare? So you're the expert.
Yeah.
Who want to cast you in the expert role? How do you manage that type of patient / client?
I wonder if the emphasis with the question is that the patient is a little bit passive. Is that how you'd interpret that, Subhadra?
I guess so. It's somebody. Yeah. It's the type of client who walks in who wants to be treated.
Yeah. Just tell me what to do. And I'll do it. Yeah.
The hardest ones to work on in my own clinic experience, get to engage and get them owning the process and all that.
Yeah, very, very hard, isn't it? When people are in that passive mode. What we would say to that is, if someone is pre-contemplative, that unless they really have the idea to change, if they're not voicing the idea that they want to change, that you're probably pushing excrement uphill. So then you do have to fall back into threat, shame, educate mode, and we just know it just doesn't work as well. So yeah, I think it's listening for that, and when people are demonstrating a desire to change, that's when you can kind of grab it and run with it. But if they're pre-contemplative, it's very hard.
Yes. Yeah. Okay. There's no other questions.
No other questions. Oh, there we go.
You've stunned them all into silence. I quite liked your discussion of the writing reflex. That's a biggie, I think. A lot of us can fall into that.
Subi, a question has come through from Aaron.
Okay.
You open up your Q&A down the bottom.
Aaron's asking, can you provide an example of how you might determine what type of exercise a client would prefer?
Exercise as in, how might you make it?
I'm not sure.
What type?
Yeah, I'm not sure about the question.
How you might determine what type of exercise a client would prefer. I'm not quite sure. Aaron, would you mind rephrasing that question for me in a different way? I'm not quite understanding what it's going for.
I'm trying to work the question out too.
Helen's just said, find it hard to incorporate these techniques, not slipping into counsellor mode. Oh, that's interesting, Helen. I wonder do you have a counselling background? And I guess counsellor is also collaborative, isn't it? So you're not always teaching or telling in that space. Yeah, that makes sense.
Yeah.
Running, walking, swimming is Aaron sort of saying. Okay. I think definitely the space that I use this most for is exercise and movement and rehab in the pain setting. And most definitely now where we're at with the science saying that walking is as good as any for chronic back pain. But more importantly than that, the type of exercise that is going to be successful is the one that the patient does. That's a real space for getting people to let their interest drive them. So I'm all for letting people choose what's important to them and what they're good at, what they feel confident that they're going to be able to follow through with.
Yeah.
So, yeah.
Okay.
Can I recommend a YouTuber or book? Not specifically a YouTuber. And the further reading, I really think Miller and Rolnick's the best place to start. There's just so much on the internet these days that you can find, and there's so much free content as well out there. Just take a little Google search around.
Yeah. Carl is asking, when the client is in pre-contemplation, but no further action is taken by them, would you nurture and encourage the client by weighing up the pros and cons? You might.
So you might start maybe drip feeding a little bit of information in a non-threatening kind of way. So yeah, gently maybe providing some of the reasons to change for them.
Yeah.
But yeah, again, that's without slipping into, I guess, director mode.
Okay. What would you say are the key differences or similarities between MI and, say, active listening? Is it similar or?
So active listening is really one of the core skills for motivational interviewing. Obviously, because this was just a short talk, I didn't get to the bit where we're actually pushing for the behaviour change, which is really, there is a real directionality to MI, and it's very process based. So you kind of go through step 1, step 2, step 3, step 4, and there's a lot of structure around it, which makes it a really lovely tool to learn and to start when you're starting out, because you've got some structure around it. You don't get too lost. So active listening is probably an early skill that helps build rapport. And really what you're looking for is to draw out people's reason to change without drawing out too much of the sustained talk. So you kind of, the idea is you would encourage and engage with the change talk, but you would roll over the sustained talk without engaging with it too much. Roll with resistance is what it's called.
Good. Okay. I'll run with one last one. Gabby's asking, when asking clients to reflect on their condition and and their self-management progress, what is helpful to get them to stop the reflection going on for too long?
Yeah, fabulous question, Gabby, because we're asking open questions, and that means that we're kind of handing the conversation over to the client. And if we're in a time-poor environment, that can be quite scary. And particularly if we are used to working with very closed questions, and most health practitioners are, we're very, we take a history there, yes, no answers. We keep control of the timing and the flow of that interview to be able to then control the whole time that we have. Now, so in a history setting, history-taking setting, using the skills like the summarizing and the the complex reflections where we bring the control back into the discussion to us, that's one of the skills. But I think for a massage or an exercise setting, this is the kind of stuff that we can do while we're treating. So it's the kind of thing you can do while a patient's on a table, or perhaps if you're working in an exercise setting, while you're having a chat while they're perhaps doing their exercises. You can be having fairly informal discussions using this, as opposed to when you're trying to get that history and you really need the nuts and bolts, and at those times you probably do need to be in control of the conversation, and you need to be asking more closed questions. So it's a good question. Thank you for that.
Yeah, okay, that's good. I'm going to squeeze in another couple. Alexandra's asked, affirmations don't always help and can sometimes make people feel worse if they don't believe it. For example, a client with depression. What could you do in this case?
That is also a good point. And I guess you'd just be reading what the client how they were responding to that. So you're absolutely right. I had a patient nearly bite my head off last week because they just weren't used to hearing positive things, and weren't used to having strong rapport with people, and felt things were getting a bit, that the closeness was a bit scary, and she got quite snappy at me, and I had to really back off on the affirmations or the affirming bits to her, because they were quite threatening. So you're absolutely right. There are times when they might not be particularly comfortable with that. In that case, you read the room and you back off a little bit.
Yeah. And the last question is from Susan, who asks, with lifestyle change, people often have many other things to change. How do you choose which to attack first? And do you ask them?
Yeah, absolutely. So again, if we want to tap into people's innate motivation, we really want them to be the driver of the process. And so handing it over to them and saying, what's most important to you? So of these things, you've mentioned perhaps 3 different things that they want to change. Which one do you feel is most important to you, and that you might have the best chance of having a go at? Really, what we want with behaviour change is to build people's self-efficacy. If there are lots of areas that need to change, we want them to have that sense of, I've got this. I can do this myself, and what builds self-efficacy is having little wins to start with.
Yeah, I like
and
that.
So setting the bar really low is a great place to start, so that people have that little win and then get that sense, and then the ball starts to roll for them a little bit.
Okay, I'm going to squeeze in one more. Is directing all bad? Some people are ready to change, but they just can't get their brain around where to start and initiate.
Absolutely. So the answer where that kind of fits is that we are the experts. We do know more than the client, especially if they are coming to us and they are in a contemplative phase, or they're ready to change. We do know more about them than about the process that they want to change. So perhaps it's exercise. So the way we kind of frame that is, when the person is expressing that desire to change, rather than doing an information dump where we're kind of loading them up with a whole lot of stuff and saying this is how you should do it, some of the ways that we make it a little bit more collaborative is to use phrases like, some people have found, and that way you can introduce information, or asking permission. So I wonder if you'd mind if I told you a little bit about what we know about pain, for example, or this is what we know about these types of exercise. Would you be interested in hearing a little bit about that? So kind of again, making it collaborative, and rather than it's just a little bit more respectful space.
True. Gee, Alison, that was a great conversation. I've really, really enjoyed that. And I hope we can do some more work with you in the future.
I'd love to do that. Yeah.
Wonderful. Yeah, that would be good.
Fantastic.
So thank you so much for coming in. I'll say goodbye to you now, and we'll move on. I think I've got to get Derek to get involved. Thanks, Alison. Talk to you soon.